Revisions for wear-associated component loosening and for recurrent dislocation of the hip are the two most common reasons for revision total hip arthroplasty, accounting for nearly 55% of all revisions. The direct costs of these revisions exceeded $500 million in the United States Medicare population alone in 2006, and these patients represent only about half of the revision total hip replacement population in the United States. Cup malposition is the single greatest factor associated with both revision for wear and revision for dislocation. Many studies demonstrate that the majority of acetabular components implanted using traditional methods are grossly malpositioned. A study published in January of 2011 from the Massachusetts General Hospital showed that half of all cups implanted there were malpositioned. Their newer study that hasn't yet been published shows that the incidence is even higher in community hospitals. Similarly, Saxler showed a cup malpositioning rate of 74% and DeGioia 78%. And the problem is getting worse. The advent of larger bearings has exacerbated things because intraoperative assessment can show a stable hip with an even more grossly malpositioned cup. This negative trend is supported by the Callanan study, which shows that the larger the bearing, the larger the percentage of malpositioned cups. This leads not only to higher rates of wear, but also to metal hypersensitivity and pseudotumor in metal-metal bearings and to polyethylene fracture in metal-on-polyethylene bearings. Not only have larger bearings made the problem worse, minimally invasive techniques have as well. The Massachusetts General Hospital study showed that more than 80% of the hips performed using a minimally invasive technique were malpositioned. What about possible solutions to this problem? Since the position of the pelvis during surgery is highly variable and unknown, measurements based on intraoperative radiographs are not only inaccurate, but also potentially dangerously misleading. Even instant intraoperative digital radiographs where the angle of the X-ray can be adjusted are of limited benefit because you cannot quantify the tilt of the pelvis on these images, and errors around this axis are often the greatest errors. What about just using an anterior exposure in the supine position? Well, this technique often requires an expensive, specialized table that can only be used in one operating room at a time. In addition, the greatest cup inaccuracy rate in the Mass General study, which was an 80% malpositioning rate, were in the hips where the cup was placed through an anterior exposure in the supine position and with the use of X-ray. What about custom templates for the hip? We have seen that these can work for the knee. But even though they don't exist yet for the hip, given the relatively limited access to the acetabulum compared to the distal femur or proximal tibia during knee arthroplasty, we can easily anticipate that this method will prove to be inflexible, clumsy, expensive, and useful for only one operation. What about computer-assisted surgery? Well, even though the problem can largely be solved using this technology, after a decade of availability, computer-assisted surgery is not commonly used. This is likely because it is too time-consuming, too complex, and too expensive. Plus, all of this expensive capital equipment can only be used in one OR at a time. What about robotics? Compared to conventional computer-assisted surgery, robotics are even more time-consuming, even more complex, and even more expensive. In addition, not only can the equipment be used in only one OR at a time, instrument reprocessing difficulties cause even greater delays and may require purchasing duplicate sets of expensive instruments just to support one single OR. So how would you feel about this problem? If you were a prospective MIS hip patient looking for the best possible operation, would you be happy if you actually knew that there was only a 20 to 50% chance that your acetabular component would be placed in an acceptable position? If you were an implant manufacturer, would you be satisfied providing 40-year-old implant alignment technology, repeatedly proven to be inaccurate, to support your latest implant technology? If you were the insurer, would you be happy about paying for quality that has the same predictability as a coin flip? If you managed an accountable care organization, would you be happy with the quality that your institution is producing and what position that puts you in going forward? As surgeons, how do we typically think? Most of us think that if we use anatomical landmarks such as the location of the pubis and the ischium, that we can do a good job. After all, these are the main bony clues that we have available to us through the incision. But the problem is, these local anatomical landmarks vary tremendously relative to the overall orientation of the pelvis from one individual to another. This means that following anatomical landmarks actually guarantees a high rate of cup malposition. Perhaps we put our cups in so poorly because we have learned to follow anatomical landmarks so well. This is confirmed by the fact that the most accurate high-volume surgeon in the Callanan study still malpositioned the cup about 40% of the time. So up to now, we have been given the choice of either using conventional methods that we hope do but know don't work, or using complex, expensive, and time-consuming technologies if our OR even has them. We need something that is simple, fast, and efficient, and that works in many ORs simultaneously without major capital equipment expense or capital risk, and that can be reprocessed quickly and easily. The HipSextant is a mechanical navigation system cleared by the FDA for patient-specific navigation of any acetabular component that performs pelvis registration, pelvis tracking, and cup orientation tracking in a single device. The FDA even created a new device category for the HipSextant, which is called a manual orthopedic stereotactic instrument. The HipSextant is the only instrument in this category. The planning is based on a low-cost, low-dose CT study performed on the day of the preoperative visit, which is securely uploaded by the CT technologist. A three-dimensional model is then created, and the standard pelvic coordinate system called the anterior pelvic plane is established. Next, the patient-specific coordinate system of the instrument is then determined by 3 points. The first point, called the base point, is located behind the posterior rim and 20 millimeters above the infracotyloid groove. The second point is located on the lateral side of the anterior superior iliac spine. The third of the 3 points needed to define the patient-specific coordinate system of the instrument is the landing point. This point is unique in that it is equidistant from the other 2 points and located on the surface of the bone. With these 3 points, the three-dimensional relationship between the overall pelvic coordinate system and the instrument docking coordinate system for that individual patient is now known. Knowing how the instrument will dock in space now allows the software to calculate the adjustments on the instrument that will make the direction indicator point in the direction of cup orientation that the surgeon desires. Knowledge about supine and/or standing pelvic tilt can be incorporated into the plan as well. The initial surgery plan is then posted to the surgeon's secure folder on the website. The plan can then be downloaded, opened on any computer in any OR, and reviewed and adjusted by the surgeon as desired, either before surgery or even during surgery. Specifically, the combined anteversion goal can be adjusted by the surgeon once the anteversion of the femoral stem is determined in surgery. Intraoperatively, once the cup is prepared, a calibrated drill guide is used to place a pin to mark the base point location. After the cup is placed into the incision, the HipSextant is slid over the base point guide pin until it touches the bone. The superior spine trocar is then percutaneously docked. The location can be probed with a trocar to ensure proper placement. The landing point trocar is then inserted percutaneously to dock the instrument, thereby registering and tracking the pelvis in space. The cup is then inserted with a cup insertion handle aligned parallel in 3 dimensions to the direction indicator, controlling both inclination and anteversion. A parallel guide can be used to fine-tune the accuracy of parallel alignment. Although a specialized cup impactor is shown here, the device can be used with any cup impactor. 70 total hip replacements performed using the mechanical navigation device were compared to a control group of 146 total hip replacements performed using CT-based computer-assisted cup placement using optical tracking. Accuracy was measured using a validated 2D-3D matching method that uses the pre-op CT to determine and account for the orientation of the postoperative radiograph. The manual instrument was statistically significantly better than the control group for both inclination and anteversion. Incision to dressing time was 20 minutes faster for the mechanical navigation group. Cup malpositioning is a universal problem in total hip replacement and hip resurfacing, which is becoming even more common with the use of larger bearings and less invasive techniques. The HipSextant system can be used in many operating rooms at the same time with no capital equipment cost. It can be reprocessed for rapid turnaround, and it is the fastest, simplest, and most efficient method of accurately placing the cup during hip arthroplasty. For more information, please visit the contact link at HipSextant.com.